So we're going to go ahead and get started, and we have, I believe, I think we can go ahead and get started with a live case. This is a live case of PVI isolation using the Variable Loop Catheter, the Variable Catheter. And Charles, can you hear us? We can see you.
We can hear you.
Fantastic.
We go ahead and get started?
Absolutely.
Good.
Please, go ahead.
Good to have the audience who sat through the entire day of cases, and we're happy to present to you a case using the Variable Catheter. Thank the organizers for inviting myself and our lab to present this case. And we'll go ahead and get started with just the case introduction. First slide just shows the people currently involved in presenting this case to you. Next slide. Dr. Choi is an electrophysiologist here also at Sharp Memorial Hospital who will present the case.
Thank you. Good evening. So our patient is a 62-year-old gentleman with two-year history of palpitations. First is diagnosed on a commercially available single lead EKG. He previously did not tolerate treatment with dronedarone. Otherwise, comorbidities, not a lot. Weight is 64.9 kilograms. His CHAS-VAS score is 0. He has no history of sleep apnea. He's currently on metoprolol succinate, magnesium, and multivitamins. Otherwise, his echocardiogram is pretty normal. Ejection fraction is 71%. His LAVI is 32, and he has no mitral regurgitation.
As you can see, we've followed the instructions for use on this patient. So our typical patient with paroxysmal atrial fibrillation. Next slide. So the Variable catheter is an 8 French catheter, which has 10 electrodes. It is the previous version of a lasso, which it's actually expandable from 25 millimeters to 35 millimeter catheter. Each electrode is it's 3 millimeters with a 7 millimeter spacing. And I will demonstrate for you just the catheter itself if we can focus in on the catheter. As you can see, it's a variable loop catheter. It's kind of the shape of a pigtail, a little bit different than the Pulse Select, which is flat. And as you can see, the electrodes are a 3 millimeter electrode, and on each electrode, there is irrigation, there's 10 irrigation ports, so each is individually irrigated and with 7 millimeter spacing. The catheter is deflectable. In one direction, it is deflectable to 90 degrees, and then it's also deflectable to 180 degrees. I can tell you that I usually don't use the deflection much. I basically use the external sheet to do any of the manipulation of the catheter. A couple of things about PFA delivery. As you can see here, there are 10 poles, and the delivery is between adjacent poles. And we also have delivery by skipping each pole, 1 to 3 and 2 to 4, which allows deeper lesion. Bipolar biphasic sequence with an 1800 volt output. Pulse trains are less than 250 milliseconds. With each applications, there are 3 applications that are done. There are 10 seconds between each application, and there is no energy, and this is important, between electrodes number 10 and number 1. So when we actually rotate the catheter, we make sure that that area that was missing is actually covered. Next. So we've already began the case already. I wanted to show this because I wanted to show the introduction of the catheter, and you can see even on the radiograph, this appears to be a large catheter, and it's with care that I put it into the atrium just so that the tip doesn't get caught. Most of the time, it's just a little bit anteriorly. And we'll go on to the next sequence here. So as you can see in this, we have already completed the ablation on the right side. What you're seeing here in purple is the tags of prior ablation lesions, and you can see pretty much with this tagging, it's pretty dense, and usually with the initial application you get a light purple, and then followed by, after the 3 applications, you get a pretty dense purple. And so I think one of the things about this is the graphics are really good. As you can see, the catheter in the atrium here, just right on the ridge area, you can see that it is green, and that tells you about areas you have not ablated as yet. So we also did a quick map of the right-sided veins. And as you can see here, we've isolated the right-sided veins. I'm not, how many pulses did we, how many total applications did we give to isolate the right side? We gave 11 to completely isolate the right-sided veins. And so one of the most important things before we get started with the left-sided veins is that the catheter has to be calibrated in order to be able to use the electron anatomical mapping system. As you can see here, we're inserting the catheter, and usually when you insert the catheter, it will turn yellow. We have this cone that you have to stay inside. Usually takes about a minute or so to calibrate this catheter as opposed to calibrating other catheters, but this is for the electron anatomical mapping system. The ones that are green are the ones that's already been calibrated, and you need about 8 of those to turn green before you're properly calibrated. And once you're calibrated, it's to further allow better electron anatomical mappings, you would actually move the catheter around in the chamber in order to get good tissue proximity. Next. So we're going to begin here, and you can see I'm just outside of the upper pulmonary vein here, and I'm going to just get our catheter situated in that vein to begin the ablation. If there's any questions, go ahead and we'll get started.
Yeah, no, it sounds good, Charles. Yeah, please go ahead. I'm just going to ask the panel a couple of questions. Maybe, Luigi, I'll start with you. So you've obviously had a bunch of experience with this catheter, and one of the things that we're all aware of was that there was some...
We're just going to go ahead and begin our first application here.
Yeah, please. Actually, why don't you wait for you to do this, and then we'll continue our discussion. Go ahead with the lesion.
One of the things that you have to be what you can be careful of, and actually the system shuts down, is to make sure that when you do the application, you can see 1 and 10 here looks slightly overlapped, but because of the pigtail, it's probably not. So I'm going to go ahead and deliver the first lesion, which is delivered just inside the vein. So let's go ahead, go. And we've already pre-medicated with glycopyrrolate already, so don't anticipate we'll get any. And so that's one sequence, and then you'll see 2 more sequences. Usually after the 3rd sequence, you can see the disappearance of the electrograms. Can you put the electrograms up there? I didn't think we pointed those out at the beginning. Yeah, actually it's there.
Yeah, now we see it. And so, yeah, that's your full set of 3.
That's the first.
He can hear you. He cannot hear you.
Yeah, go ahead, Nasir.
He cannot hear you. I'm saying he cannot hear you.
I think he can hear me. Charles, you can hear me, right?
I can hear you very well.
So
Charles, I'm going to just turn the cat. Go ahead.
Quick question. I'm glad you mentioned this at the beginning. I think this is one of the most important aspects of using this catheter is the calibration at the beginning. I think spending the 30 seconds, because that's where the misleading contact of the catheter with the wall, with these bubbles you're showing here. If you don't calibrate it well at the beginning, if it's touching a wall, people tend to put the catheter through the sheet and you'll be touching the first 2 electrodes somewhere in the wall and you calibrate it. But it's key that these 2 electrodes should be free floating in the atrium before the calibrating happens. Is this what you also aware of and usually do?
Yes, absolutely. It has to be free floating, and sometimes depending on if your chamber is a little bit flat in the AP diameter, it can be a little bit challenging. But what we found is that if you start with the sheet up high and then let the catheter come out of the sheet, and also at some point, once you get 2 or 3 electrodes out, you have to start sort of reducing the curve on the catheter, or at least reducing the size of the catheter so that it stays in the middle of the chamber and there's no contact. So I agree.
Charles, we're just over half the time, so please go ahead with the ablation.
Okay. So we're going to go ahead and deliver the 2nd lesion, which is inside the vein here. Go ahead.
Yeah, go ahead, Luigi.
No, Vivek, you had a question.
Yeah, I wanted to ask you in terms of patient selection, right? Because as we know, there was some issues with some embolic events, and there are a couple of mitigating sort of strategies that we have. One is to not deliver repeated applications at the same location, but also patient selection. Can you talk a little bit about the kind of patients you're...
Well, right now, I think recommendation is to utilize this for what the catheter was approved for, and the catheter is approved for paroxysmal atrial fibrillation. So the patient that is being included today is perfect, a patient with normal heart, normal EF, and paroxysmal atrial fibrillation.
Will you just go ahead and deliver the antral lesions?
I think this is a good candidate for this procedure, or a patient where you plan ahead to perform a PVI only procedure. So for a PVI only procedure, I think this catheter is a good one. Another information that came from the trial was not to exceed 20 to 24 application. So the recommended application are basically 8 by, it's 4 for one side by 2 8 is 16 basically. So I had 2 questions for him, which is why you had to do 11 application is because you could not isolate the vein or because you had to do something. And the second one is, what's your ACT level?
Our ACT levels, we make sure that we go above 375. Go ahead and apply the lesions. We ACT, we make sure we start greater than 375, but I've actually been starting at 375 or above on my ACT. And regarding your initial question, remind me the initial question there.
The first question is why you had to do 11 application on the right side.
Well, I recognize that the recommendation and instructions for use on this catheter is 24 total. We're still within that boundary of that of doing that, so I don't think we're outside of what the recommended use is as yet. And normally I don't necessarily map. We can assess with pacing when we deliver the lesions. Go ahead and deliver a lesion here.
Yeah, so
we can assess with pacing, but I ended up mapping afterwards, but I wanted to make sure that that vein was completely isolated. So it wasn't an issue or any problems isolating.
Irrespective of the recommendation, I'm saying you had to do 3 more because you wanted to do reinforcing lesion or because you had some signal that you wanted
I wanted to do reinforcing lesions, and I did a couple of antral lesions, both a little bit anterior and a little posterior.
One question for the panel is that with this specific technology, I have not seen much of the vagal response. I don't routinely apply the glycopyrrolate, which I actually do with other technology. So any experience from the panel in this?
Daniel, you want to comment?
Yeah, sure. So first of all, I think this is an ideal candidate. Coming to your question, Luigi, we systematically apply atropine, so I cannot really say anything about vagal responses. I'm not aware of vagal responses in the IDE studies, especially in the European studies we were part of. One thing I'd like to comment, I know, and because this is on everybody's mind when he sees this catheter, I know there has been issue in one specific study here in the US. I want to add that we did not see this in the European experience. We're also running a quite big registry in Europe called the Secure Registry. We are presenting part of that data in HRS, and so far, without disclosing too much, not a single cerebrovascular event has been reported within the strategy. Of course, keep in mind that in Europe, we would rather stick in all these, especially small patients, to PVI only. One additional question I wanted to ask you, Charles, do you sometimes give carinal applications? And what do you do with left common ostia? Do you go with a segmental approach, or how do you deal with if you have a left common ostium with this catheter?
Well, with the common ostium, I tend to go segmental in my approach to the ablation. And the reason why I tend to give, obviously it says give, total of 4 applications per vein. I tend to actually give 2 additional lesions, 1 anterior cariner and 1 a little bit posterior, just because these are the areas that I tend to see areas in the past where I've actually had some residual conduction. So pretty much this vein is isolated, and I've stayed within the recommended number of applications and did give one more annually. But if you look at this right now, I'm looking at the carina area, and you can see that there's just a slight area there by the appendage. And this is the I think some of the problems that we may have ran into earlier on is that you have all this information, and when you see light purple, I think that there were probably more applications of energy where there's light purple because we didn't get this bright purple color in place. But as you can see, pretty much right now, these veins are isolated, and how many extra pulses did we take to isolate these veins? And I will do a quick voltage map after removing the catheter just to be sure. And one of the other things I want to point out about this catheter is you can actually go back into the veins, and I'll go back into the veins, and you can actually pace to assess for exit block. So let me just have you just go around and pace from each pole. We usually do it at 10 volts because the antenna on these volts are usually pretty high. And we look for any capture here. I mean, one of the places I'm really concerned about it right now is 1 and 10, but I don't think that you'll see any capture in this area.
Charles, if I may, one more question. I mean, obviously you have those TPI indicators to assess contact. Now, what do you do with electrodes that are not in contact? Do you actively shut them off, you know, with to avoid hemolysis and stuff, or do you just stay on with all electrodes in your applications?
So I stay on with all electrodes. If for some reason they are in contact, the machine will shut down. If I can see, like if I'm in a very small vein, and I see that there's overlap, I will automatically shut them off before we go. So we just paced around this vein, and it's pretty much completed. So I'm going to remove the catheter and do a quick voltage map, which most of the time I usually just end up doing a quick pacing maneuver, and that's usually the end of it. So this patient is strictly a PAFer. We did testing before. So this has pretty much completed this aspect. So I'm happy to answer any other questions.
You know, I have to say, I remember when we were doing the cases, my routine strategy was 7 applications per vein. So it was certainly higher than 4 per vein. And again, we had no problems.
I can't help myself right here, Vivek, because I'm going to apply again. Just right in this area.
Okay.
Because I don't like exchanges, you know?
Yeah.
I fear exchanges more than doing, so let's go ahead and give one more application here.
Yeah, no, I have a feeling that the patients that you select are important. That is, when you start getting more persistent patients, when you have greater amount of disease and slow flow, I have a feeling that that's going to affect things quite a bit. John, have you played with this catheter?
I have not used this catheter. I was going to ask, you know, in terms of the indicator of approximation to the tissue, what is the tactile feedback like on this catheter? Does it usually, is there consistency between whether you feel you're in contact and what the indicator shows you? Is it somewhat disparate?
I think one of the things that people say about this catheter is it feels a bit stiff, but I didn't show you, and maybe you didn't pay attention, on the bottom part of this screen, there is an impedance map from each electrode. So I tend to make sure that I look at the impedance in addition to the graphics that you see, and the impedance is usually around 170 when I have good contact, and so I also pay attention to that. But the catheter is a little stiff. I can feel it when I'm up against the wall, and I make sure that I do put pressure because I do believe that contact is very important. And so that's actually, I think it's very important, but it is a little stiff. And although the instructions for use sort of says, you know, I wish we had perfectly beautiful rounded veins, and this catheter tends not to be compliant. It actually deforms the atrium, so you have to be. So here is the upper pulmonary vein here. As you can see, that's Charles, isolated.
Yeah, Charles, we're gonna we have just about another minute or so. As you're doing this, one question Louisa was just asking, what's your experience with using the ablation catheter, the Varipulse catheter, to do the mapping at the end?
I mean, you don't like exchange.
I don't like it because, you know, I think it's just a matter of like, I feel it's kind of stiff. I don't move it around. But as I said, I usually go through and do pacing around each of the veins. And if that's okay, sometimes I don't even bother going back and looking at and seeing and doing a voltage map. And we're just doing this for demonstration purposes here. And as you can see, these veins are isolated.
And one thing that, you know, we didn't highlight enough is, you know, you could do this with basically no fluoro. So this technology allowed that. We want to comment on it?
Well, I think I agree that you can do this with, and that's the way it can be done without fluoro, but I think the fact that you have an electron anatomical map, it allows less fluoro. Like, I think most of my cases, I'm not a zero fluoro person, but most of the cases I've done have all been under 1 minute. And I actually just like the tagging features that allows you to see areas that you visited before. So, I think that's the benefit of having an electron anatomical map. It's definitely the fluoroscopy. And I think the integration with the mapping system is actually the strength of this system. The workflow for me has not changed much from RF to this. And then I can immediately, if I have a flutter, I'm in the same system and I do change out to an RF catheter in order to do flutter. So that's pretty much the case here.
And I would say something to people who use the Varipulse, especially the users who get used on the Farapulse and try to use the Varipulse, don't expect, all the users of Farapulse, we do a lot of lesions safely. And then you try to convert this into your mind to this catheter, which is not the case. This catheter, in my opinion, you don't need to do that amount of lesion to achieve the same goals. I think there's data coming out in terms of MRIs and follow-up. So keep this in mind. I think with 20, what the Europeans been doing applies very well. I mean, the data from Europe, safe, with more 3,000 patients, because you don't need to do 50, 60 lesions like in the Farapulse catheter. I think this catheter...
You're absolutely right.
Lesion with shorter period of time.
Yeah, so Charles,
because if you think of the delivery... Yeah, go ahead.
No, I was just going to say, we're just about out of time. So if you want to just wrap up, and well, thank you.
No, that's basically, I agree with him in terms of the number of impulses, because you're delivering between so many electrodes, the field that you're delivering, you won't need to deliver in excess of 24 pulses. And that's it. So thank you for
Great case.
your
Thank you, Charles. Fantastic.
participation and discussion.